Hi, Daniel.
Jen, Ashley, Jesse, good evening. Jesse, who's your instructor?
McBride.
Okay. Okay.
Mine is also McBride.
Yes, I recognize your name. Okay, good. So I started the recording so I could save the information here. So what I'm going to do tonight is go over the PowerPoint that we normally don't go over, the overall exam PowerPoint, because it covers all the concepts in case as we go through, you know what questions you would have about it, and we can slow down on each concept then. So how is med surg going for everybody?
Good. It's going good.
Good,
Going
good.
all right.
Yeah, it's going
Doing
all
all
right.
right.
Daniel.
I'm just ready for the term to be over.
You know, I was thinking, we're going into week 4, and before you know it, it will be done because you take your first exam this next week, and then in week 7, you take your second exam. So before you know it, and then week 9 is the third, and then that's about it.
Yeah, I mean, even this year has gone by really fast. I mean, it was January, and now tomorrow's the first day of May.
I know. Yeah. Yeah, I agree. Going by quickly. And I live in Michigan, so we're going to have cold this week, down in the low 30s. So our frost date isn't till May 25th, and I like to do gardening and stuff. So yeah, I'm anxious to get outside and really start doing stuff, but it's too early. So what campus are you from, Daniel?
I'm from the Cookville
Okay.
campus of Tennessee.
Okay.
All of
Yeah.
us are
Yeah.
actually. We're all in
Okay.
the same class.
Okay. Jesse, you're from Cookville as well?
Yes.
Okay. So other than Crystal, none of you are taking your exam on campus, correct?
Yeah, I'm taking mine online
Yeah.
tomorrow.
Yeah.
I'm taking
Yeah.
mine on campus.
Okay. So yes, Ashley, you are. Yeah. Okay. All right.
No.
That's interesting. All right. So you don't have to, those of you on campus don't have to be on Zoom, correct? You don't need to be on Zoom if you're on campus being proctored with Professor Huddleston, right? Yeah. So you don't need to be on Zoom since she's proctoring you. So I have the exam set at, you can download starting at 2 p.m. tomorrow, and that's Eastern time. So for you, that's 1 p.m. Okay, you can go ahead and download your exam.
Is that usually with all the teachers or just with you?
Yeah, it should be.
Okay.
Yeah, I know Professor McBride does it that way.
Okay.
Professor McBride and myself are the only 2 full-time OB instructors. The rest of our instructors, all the other 5 of them, are just part-time. Have you watched any of the short videos to get ready or attended any other review sessions this past week?
I've watched some of the previous videos, but I haven't attended any ones like this one.
Okay. Okay. So make sure you do watch some of those other if you have time. You have you're taking your exam at, I forget what time tomorrow? At 9:30?
Yeah, for those online, or on campus, we're taking it at 9:30 in the morning.
Okay, okay. So it's really important that we do a good review tonight.
Yeah.
If you've not attended any other sessions, okay.
It was hard for me because I had med-surg clinical this week and OB clinical. So, and then I had a care plan to do, so that took up a big part of my time. So that's why when they was talking about you being on later this evening, I was like, yep, I'm going.
Yeah, and that's why I like to do it late, on Sunday, because we didn't have any on, I did one on Friday. I did a session on Friday also. But I didn't get it recorded. I messed up the recording, and we didn't have any review sessions yesterday. On the weekends, we find that students are working or they have clinicals, so that's why I do Sunday night at 7. Hi, Katie. Who's your instructor?
Professor McBride.
Okay.
Yeah.
I'm glad you're here. So, Katie, have you watched any or attended any of the other review sessions this past week?
I have. I went to 2 others.
Okay, good.
Yeah.
Okay. So during this, Mabel, where are you? She's lost her now. There you are. I renamed you, Mabel, and now you're iPhone again. I know who you are.
Yes, I'm here because I wanna beat that exam. I wanna do good.
There you go. Yes.
Yeah, I
Yes.
have been studying.
Good. Good.
Yes, all day. And I'm
All
very
right.
excited to be here.
So
Very
so
excited.
that means that you might have questions for me,
Oh,
right?
Mm-hmm.
Hi, Rebecca. It's good to see you too.
Hi, how are you
Yay.
doing today?
I'm doing well.
Good. Good.
I'm glad to see some. Go ahead. I'm sorry.
Oh, I was just saying, I was just finishing up the NCLEX questions and everything like that. So,
Okay. I had some students that didn't submit their questions correctly. So if you're one of those students, let me know and I'll show you how to do that. You can share your screen with me and we can work through that. Okay. I know the online course is so different than what you're used to. So just let me know if you need help with that. I don't remember who all it
I was going to
was.
ask about that because in the description it said, how you showed us to save it as a PDF. And then I put my PDF in a Word document. Is that okay?
Yeah,
'Cause the way
that's okay.
the way my computer did it when I went to the save the PDF, it didn't give me an option to put it in the folder on my desktop in the OB folder so that I could find it.
Okay.
And
So what you
I
might
just,
do, you could save it on your desktop and then go back to your desktop and then move it.
yeah, that,
You
see,
can do that.
it wasn't giving me an option to save it.
Okay.
So I saved it where it was and then I just put it in the Word document.
Okay, all right. So as long as it's all of the pages of the
Yeah.
PDF, all of them, it shows me the maternity ones that you did, or at least the number in your score. And it has your name and date and time on it, as long as I get that.
Yeah, I
That's
got
all
all
I
the
need.
pages, so.
Yeah, and some students, if they submit a screenshot and they just still don't understand how to do it, I'm not going to ding you if we don't get it corrected until Tuesday of the week, the following week. That's okay. As long as you submit something by midnight tonight, I will help you learn how to submit it correctly. It's just one of those technology things that you have to learn how to do. And you need to know those things as a nurse. So I could be glad to help you with that. So we can do that.
so I just submitted a screenshot of mine to McBride's because I had no idea. I mean, I read the description and I tried to follow through like you were supposed to click content area and then hit maternity, but then it didn't give me another option to select like antepartum or.
Well, you have to click there's a down arrow that you click.
Really?
It's
Yeah.
to the left. It's to the left, Ashley.
Of
You'll see
the
it.
word,
It's real
yeah.
faint. It's to the
It's-
left of the topic.
of
Oh, I had
maternity.
no idea. So
Yeah,
I
yeah.
probably done those incorrectly.
You probably did questions that you wouldn't know, so.
Well, that's why I text Crystal and a few of the other people, and I was like, these are awful questions. Like, I'm doing terrible, and I don't understand why these
No
are so
wonder.
awful. So,
Crystal,
yeah, it's
Crystal
probably
said
why.
she had to shut down her computer and reboot it, and then she'll be back on. Hopefully.
Okay. All right.
Ashley, you do know that you can go, like after you've done one, you can go back and review it and you can click on rationales. So it'll
Yeah,
show
I
you.
knew that part.
Okay,
I
okay.
knew that,
'Cause
and I
that-
was doing it.
that-
But even, I mean, after I'd done them and I read the rationales, I was like, well, I would have never known that, so,
I feel that even for questions we should.
yeah.
So you're ahead of the game then, Ashley. So what you could do if you wanted to go back in and just do like a group of 10 of just the intrapartum or antepartum and just do small groups, just so you'll get some good experience with the questions. But
Okay.
hang on after we get done tonight, and I'll make sure you get those uploaded correctly.
Okay. Well, I already submitted the screenshot to Professor McBride, so
And
I'm
she'll
sure.
say no screenshots, and she'll put a 0.
Oh, God.
So let's you and I make sure we get that fixed tonight, okay?
Do I need to send her an email?
No, not right now. No, we'll get it fixed and you can resubmit.
Okay.
Yeah, you can resubmit as many times as you want. It's okay for the NCLEX questions.
All right.
Oh, there's Crystal. Okay, Cassandra's here, Lisa's here, Alicia's here, Siani's here. This is great. Got lots of people here. And it's now 7:01. So let's get started. So I have pulled up the exam 1 PowerPoint, the long one. And so we're going to go through the PowerPoint, and I'm going to go slowly, and we're going to add in some questions so that we're covering the very important concepts from weeks 1 through 3. Now, remember, the exam does not cover postpartum, which we're doing this next week. Okay. So those of you, by the way, those of you who are testing on campus, make sure when you're finished your exam, make sure you sign into Zoom for your class time at about quarter after the hour. So so for you, for those of you in Cookville, it would be 3:15. So sign into class at 3:15 so that you get credit for attendance for the rest of the time. Okay, so it would be 3:15 your time, the central time, 4:15 Eastern time.
So are we staying after the exam? So are we just like turning our cameras off and then doing lecture after the exam?
Yes.
Okay.
If you're not testing on campus, you're testing with me online. When you're finished your exam, just turn your camera off, go take a break until 4:15 or so. Usually it's closer to 4:30 before everyone is done. Okay. All right. Adriana, hi.
Hi. Hi,
You are
Professor.
not required to have your cameras on for this review, but I enjoy looking at you. And let's see, iPhone. Let's see, let me guess. Oh my gosh. iPhone, just iPhone. Who's that? Not you, Mabel. Who's the other iPhone person here?
I have an iPhone.
But your name is on your Zoom.
Does it show? Okay.
Yes, your name is showing. Oh, let's see. It's Nisi. Okay, Nisi.
Yeah.
Thank you. Thank you.
You're welcome.
Okay, great. That way you get credit for being here. Okay, let me get.
Lisa Burgess just said in chat that her camera is working.
Thank you, Jen. Yeah, that's fine if your camera's not working, but it needs to work tomorrow for your exam.
Professor.
Janique is okay. Janique is with you. Okay, great. Now,
Professor,
are you two
my camera's not on because I didn't want my baby to be a distraction. That's all.
Oh, what a cutie.
Thank you.
Your baby's a nice distraction. Okay. Okay, Lisa, thank you for letting me know that Janique is there. So that way she gets credit. Okay, let's get started.
And those of us taking the exam at Cook on campus, now are our exams already on there to download?
They won't be ready for download until 2 o'clock tomorrow.
Okay, she's doing the exam at 9:30 in the morning.
Oh, I need to fix that. Thank you for letting me know. Oh, gosh, I didn't put 2 and 2 together. I'll fix it.
And I'm taking the exam at 1 p.m.
Okay. Oh, my goodness. Thank you, Crystal.
Well, because
So I'll change it to noon, okay? So you can download it at noon your time. Does that work for everybody?
She's doing the exam at 9:30 our time.
Oh, 9:30. Okay. All right. I guess
Yeah,
I
she
have to
said
do it
the
at
exam-
8:30. Okay, 8:30
Okay.
then. 8:30 or 8 o'clock Central Time. All right. Made myself a note. All right. We got that taken care of. Oh, Adriana's got a little one with her too. See, when we do exam reviews, we're not as strict. It's who can be here. Okay. All right. Let's get started. All righty. Let's start out with a practice question. So, do you know what the term teratogen means?
Okay.
Does anybody know?
It's
Okay, let me explain.
It's a
You probably-
medicine that's harmful to the baby while you're pregnant.
Yeah, so it could be a medicine, it could be environmental exposure too. Anything that could cause damage to a developing embryo or fetus. Absolutely. So as a nurse, you have discussed teratogens with a client during a preconceptual counseling session. Okay. The client demonstrates understanding after making which statement?
D.
D.
Say D
Yes.
too.
Yeah, D is
It's D.
correct. Yes. After 12 weeks, the placenta placenta doesn't protect the fetus at any time. It doesn't filter out viruses, bacteria, or other toxins from the blood. Okay. First 16 weeks, no, it's the first 8 weeks that they're most vulnerable to some kind of teratogen that could damage or delay development. It depends what medications our client is taking. So we don't want to stop all medications. If she's on a thyroid medication, we don't want her to stop. Okay, so we need to review her medications. Other than we do, it's really important. And if we do preconception counseling, doing a history is really important to plan a pregnancy. If she has some kind of genetic disorder herself, and we'll talk about genetic or some kind of historical chronic illness in week 5 that can cause problems. But when we do a history, we collect so much information about our client. We do a head to toe physical assessment. We teach. Okay, nurses are teachers. Okay, we screen for psychological problems. We screen for exposure to drugs, exposure to violence, intimate partner violence, human trafficking. You need to be familiar with some of the symptoms or signs of a client who is experiencing trafficking or violence of some sort. Okay. So what's one thing that you might notice in a client that's experiencing violence?
Anxiousness.
Okay, anxiety, absolutely.
They won't make eye contact.
Okay,
Old and new bruising.
okay, old and new bruising. Good point.
They would
Maybe
look
I might
at
not
your,
leave their side.
Yes, the person who attends with them during visits is very dominating, and they do not want the client to be left without them being present. Yes, good. Anybody else?
they would look at their partner to respond to questions.
Can you repeat that, Cassandra?
They will look at their partner to respond to questions.
Oh, yeah, yep. Okay, good. They also tend to come to the prenatal clinic more often with vague type symptoms. Okay, it's almost a subconscious cry for help. Okay, all right. We also do that first prenatal visit. We do a physical exam, and part of that physical exam is not just head to toe, but also a pelvic exam. So we're going to assess the cervix. So we need a speculum into the vagina so we can see the cervix and the tissue, and then we're going to actually palpate the cervix and the uterus. So it's called a bimanual exam. So we can see a little bit of information about the anatomy. And we do cultures. What's the age that we do the first pap smear? What's the guidelines tell us? Age 21. And we know that's because the human papillomavirus, HPV, usually doesn't cause problems before the age of 26. Okay.
So you mentioned this in class. If the person is not sexually active, do they need to have a pap smear at 21? Okay, not until they're sexually active, but not until their 20s.
Right.
Okay.
So Alicia, like if you have a client that has a severely developmental delay, maybe severe cerebral palsy or some other kind of neuro damage, and they've never been sexually active and they're 40 years old, we don't need to do pap smears. We do physical exams to make sure the tissues are healthy, okay, and just a typical exam, but we don't do pap smears on them. Okay. So another question. So you are teaching your client about avoiding laying on her back. She's 30 weeks pregnant now. And what is your reason for teaching this?
WB.
Placental perfusion. So somebody want to describe that?
When the pregnant woman is laying on her back, is pressing on the vena cava, and that is like cutting the oxygen and the blood supply for the baby.
Very good, Adriana. Yes. So when the vena cava is compressed, not only does the mother receive reduced perfusion to her brain, so she gets a little lightheaded, right? The baby also suffers. Okay. So let's look a little bit at look at the bottom left of this slide. Placental perfusion. If you look there, you see the fetus, the amniotic fluid, and you see the umbilical cord. And you see how that cord is connected to the mother, the blood vessels. Okay, so this is the inner lining of the maternal uterus. Okay, you see the blood vessels, the maternal arteries, the uterine wall, and how they're intermingled in the inner villus space. So if the maternal blood is not at low pressure but high volume, then the fetus is going to receive reduced oxygenation and nutrients. Okay. So we know about fertilization. It occurs in the fallopian tubes and becomes a zygote. Okay. The combination of the sperm and the egg makes a zygote. It flows through the fallopian tube, and at days between 7 and 10 or 12, it will implant in the wall of the uterus. Day 15, it becomes an embryo. Okay, and then at week 9, it's referred to as a fetus. So the fetus needs amniotic fluid. Okay, the amniotic fluid will maintain an ambient temperature around that baby, will provide buffer, and allow the baby to grow. The umbilical cord does nothing but serve as a channel of blood flow. It doesn't do oxygenation, it doesn't filter, it doesn't do anything other than a channel. But it is important because it protects those blood vessels. So we have one large vein and 2 small arteries. The fluid is made up of, who can tell me what amniotic fluid is made of?
Baby's urine.
Okay, the baby's urine.
Isn't it like respiratory secretions?
Yeah, the
Baby's waste.
secretions from the lungs, absolutely. And it grows with the baby. The amount grows with the baby. Okay, and it's a really important thing to keep in mind if we have someone who's high risk. We need to know what the amniotic fluid volume is. If it's too much, it can be a problem. If it's not enough, it's even worse. Okay, so oligo and polyhydramnios we talk about in week 5. So what are some things that can affect the blood flow from the maternal arteries and veins to the fetus? Maternal arteries to the fetus. What are some things that can affect the quantity of the blood?
Cord compression.
Cord compression.
Can you repeat the question?
Yes.
Could you repeat the?
Yeah. So what can affect the oxygenated blood, the sufficient amount of oxygenated blood from getting to the fetus?
Like hypotension?
Okay, so mother's blood pressure isn't high enough to provide the blood volume to the placenta. Good. What else?
Circulation.
So be more specific about circulation.
Does it have to do with the when the placentas form, the vessels that are there, if they're not formed correctly or they're damaged, the flow won't go through? Or
Okay,
perfuse?
usually, yeah. Well, that in that case, it might be that baby will be aborted spontaneously. But also, Jen, if there's a 2-vessel cord, we might only have 1 artery, which is not super serious, but we need to keep an eye on it. Okay. Okay. What else?
Would it be like anemia in the mother?
Okay. Okay. Oh, very good. Mother has anemia. Yep. So not enough red blood cells to carry the oxygen to the baby. Okay. What else?
Is it
Could it be?
obviously placental perfusion, like contractions, maternal blood
Okay.
pressure?
Yeah. Yeah. Both of those, Katie. So during a contraction, when the uterus is contracting and squeezing, the blood flow is reduced. Okay. And then also blood pressure, Katie mentioned. So if the mother has low blood pressure, okay, it's reduced blood flow to the uterus. Because whenever a person maybe has low blood pressure because they're going into shock, if they're losing blood, the blood is diverted from every other organ except the brain and the heart. Okay. So blood volume, blood pressure, anemia, those are and all those things are good.
Professor, could it be also COPD?
Higher levels of carbon dioxide. Yeah, it would affect. My concern with that would be, does a baby, intrauterine growth restriction. So other than blood flow, smoking, COPD, smoking, high levels of nicotine reduces blood flow to the placenta. Sometimes drugs. Yeah, good.
Can I ask a question with the contractions part? So if
Yes.
the mother was having a lot of Braxton Hicks, would that cause a lot of like decreased oxygenation? I genuinely don't know. So
No, I don't think Braxton Hicks would do that. It's generally a tightening of the abdomen. It's not a true contraction, and they're
okay.
irregular. Yeah, I don't but I've not read any studies on that.
Okay.
I don't know. So here's just another picture of placental perfusion, and we just talked about it, but it's just a better depiction. So we have the fetus and all the fetal blood vessels and how they wrap into the cord, and then the mothers, they don't mix. There's just a single layer of cells between the mother's blood and the baby's blood so that things can pass back and forth to provide to the baby. I just thought it was good pictorial. Okay.
That's 4.
Yeah, I already have the excretion crossed out, so that one wasn't right. From a previous session. Yeah, there's no where does the excretion occur?
On the baby,
From the
the
baby.
amniotic fluid.
Yes, yeah. Baby doesn't pass any bowel movements during intrauterine life because all the nutrients are already broken down. So the bowel is quiet. Okay, but baby does produce urine. Okay. So the answer is this one. Okay. That's the answer. Placenta really doesn't do much filtering of alcohol, even though it's very simple to metabolize. It doesn't, and that's probably why it's not filtered, so the baby can be affected. So we do some antepartum testing, a lot of antepartum testing, dependent on the mother's not only medical history but her pregnancy history. Okay. One thing we do for every client is we do carrier screening routinely during that first trimester. Carrier screening can be done outside of pregnancy. We can do carrier screening for cancer genes in women who have a history. Her mother had breast cancer, maybe a sister had breast cancer. If there's a long history, we can do carrier screening to see if she carries a gene for breast cancer. But in pregnancy, we determine if they're carrying a gene for sickle cell or cystic fibrosis and other ones based on their history. Okay, but routinely we do the autosomal recessive testing. Okay, so both mother and father have to be carrying the gene for a baby to have a risk of developing a disease. Okay, so for example, autosomal recessive means that both parents have to be carrying it, and then 1 out of 4 babies will actually have the disease. 1 out of 4 will be healthy, and 2 out of 4 will be carrying the gene also, but not be sick. Whereas dominant, it only takes 1 partner, and half of the children are going to have that same disease. You don't have to know anything. Go ahead.
I have a question. I know the oxytocin is given to promote the contractions, right?
Mm-hmm.
And then the prostaglandins, if that's how you say it, what they're used for?
Prostaglandins are used for, it depends. We use prostaglandins to help prepare the cervix for labor if we're inducing labor. Okay, it helps the cervix to soften and dilate, to efface. Okay, we also use high doses of prostaglandin in postpartum to cause the blood vessels from the mother's uterus to constrict where the placenta was.
So when the mother is like going into labor, can the prostaglandins be given before the oxytocin to help the cervix to relax and efface, like go like thinner?
Exactly, Adriana. So if we're inducing a client, and this week during class, we're going to talk about our 40-year-old client who's 42 weeks pregnant, and we had to induce her. So we are going to use a prostaglandin to prepare her cervix before we give the oxytocin. Okay? Okay, good. So does everybody understand about autosomal recessive and carrier screening?
Yeah,
Yes.
I understand, but the autosomal recessive is more routinely during the first trimester, you said?
Yeah, we don't have to do it. We can do it later. If she shows up at 28 weeks and this is her first prenatal visit, we can do the carrier screening then.
Okay.
Because it
Thank
doesn't
you.
change. Yeah.
Okay.
Are these ones done with a maternal blood test or with an amniocentesis?
These are done initially with a blood test.
Okay.
Okay. And we can't see genes with amniotic fluid. We could perhaps pick up some genes if we did like a chordiocentesis. Okay. Whereas the maternal marker screening, this can only be done between weeks 11 to 20. And you don't have to know that, okay? But this is something we only do during pregnancy. And we're looking for proteins in mother's blood, okay? Particularly AFP. That's the one you need to be most familiar with. There's 4 different ones that we can look at, but AFP tells us a lot of information. So we usually do this during the, maybe it depends how far along she is when she comes in. So we're looking for alpha fetoprotein. And so if alpha fetoprotein in mother's blood is low, then there's an indication that the fetus might have Down syndrome if it's low. So low down, AFP low down syndrome. Okay, AFP high, a neural tube, which is the spinal cord, the spinal nerves in the spinal cord defect. So how do we know that? What are we teaching mother early, preconceptually or early in pregnancy that she needs to help prevent neural tube?
Taking folic acid.
Yeah, folic acid. So the AFP level is going to be high in mother's blood if the fetus has a neural tube defect. So the AFP is all you need to know for this class, okay? So other than blood tests, so if we have a client that has low levels of AFP in her blood, the next thing we're going to do is an ultrasound. We can see around week 16, 18, 20, some signs in the ultrasound that baby does have Down syndrome or probably has Down syndrome. They're missing a nasal bone. Okay, they have a thick nuchal, which means neck translucency. Their femur and their humerus bones are short. Okay, so some things we can see on the ultrasound. If we see those things, then we do give the option to the client about week 15 or 16 to do what's called an amniocentesis. So what we're doing with an amnio is drawing the fluid to see the AFP levels in the fluid, which are more sensitive. Okay, so if we have high AFP levels in the fluid, then we can almost for sure say the fetus has a neural tube defect. We can sometimes see a little bit of that myelomeningocele along the cord somewhere, either high or low in an ultrasound. kind of hard to see. So usually, diagnosing neural tube defect doesn't occur until, for sure, until delivery. If we highly suspect a neural tube defect in a myelomeningocele, we do a C-section to reduce damage to those nerves. And I don't know, some of you who maybe are familiar with OB nursing, some of the, quite a few years ago, they started actually doing intrauterine surgery where they go in and close off that neurotube, help reduce damage to those nerves. Okay, so amniocentesis early in pregnancy is to find out about the AFP levels. So there's some risk associated with this procedure. It requires an informed consent. So what are some risks that you can think of sticking a needle in her abdomen to draw some fluid out?
Infection.
Infection.
Rupture.
Rupture of the membranes. Or, yeah, go ahead.
Miscarriaging.
Miscarriage, or it depends how far along she is. If she's 16 weeks, it would be a miscarriage. If she's farther along than that, it would be preterm delivery. What else?
Hurting the baby.
Hurting the baby, injuring the baby somehow. Okay. We can actually cause labor. Okay. Or injuring mother somehow. Okay. So we need to monitor the baby as we do this. And we keep the mother in the facility for probably several hours, monitoring the baby, making sure everything looks good, doing some ultrasounds, and looking at the amniotic fluid. Okay. So late in pregnancy, we can do the same procedure. So one thing you need to know that fetal lungs are mature at 35 weeks. Cassandra, she's got.
I'm sorry, I missed out on something. When you said if they find low AFP, that might be Down syndrome, and the next thing you have to do is an ultrasound. And what you can find on an ultrasound again?
For Down syndrome, we would, and you don't need to know this, but just know that we need to do an ultrasound just to see if we can see signs of Down syndrome, like a short femur, a short humerus bone. Okay. Absent nasal bone. Those are typical findings of Down syndrome.
Thank you.
So those would be low AFP levels. Okay. We can do an amniocentesis late in pregnancy, that third trimester, right before delivery, to determine if those fetus lungs are mature. Okay. So usually at 35 weeks, fetal lungs are mature. They have sufficient surfactant. It's that slimy solution inside the alveoli that allows the alveoli to expand and stay expanded for gas exchange. Okay. Prior to 35 weeks, there's probably not enough of that slimy surfactant, and so the fetal lungs aren't mature. But at 35 weeks, they usually are. Okay. So it's also referred to as an LS ratio of 2:1. There are two substances found in the alveoli. Okay. So when we do chromosomal testing, like the AFP levels, we can determine if the AFP is low. It might be a trisomy. So there's all kinds of trisomies. In other words, the quantity of autosomes is more than what a human needs in the cell. Down syndrome is a trisomy number 21. Edwards syndrome is a trisomy 18, and then trisomy 13. Survival rates are very low for trisomy 18 and 13. Severe retardation or not or developmental, neurological, inadequacy, you might say, all kinds of heart problems, digestive problems, and you can look in the details. But for a Down syndrome baby, which is much more common than the other two trisomies, what age of woman is at greatest risk for a Down syndrome or some kind of trisomy?
35 and older.
35 and older.
So an advanced maternal age of 35 or older, okay? Yeah. They're not all considered fatal or early death, mortality, but the Edwards and Apatow, pretty much within that first few months they are. Down syndrome, no. Down syndrome, it depends on the severity, because there's different severities of Down syndrome. They could live 30 to 40 years. Okay. Here's just another picture of neural tube defects that I put together. The one on the top is called anencephaly, minimal brain tissue. Okay. The neural tube just does not form right. The brain and the spine are damaged. Sometimes this baby might be a stillborn. If they're born alive, they're not going to survive very long. Okay. And remember, the neural tube should be closed and fully developed by 8 weeks of the pregnancy. So the neural tube defects, you know, we talked about not vitamin B9. I have a granddaughter with a neural tube defect. Hers is very low. The lower the defect, the better the child will do, the baby will do. My granddaughter Zoe if there's a defect like this, they have surgery right after they're delivered. Well, shortly after, within 24 hours, they go ahead and close up, put those nerves back inside the body. But those nerves are already damaged. So Zoe, my granddaughter, does walk. Okay, she has what's called a neurogenic bladder. She has to catheterize herself to empty her bladder. So it's spina bifida. Okay, that's more than what you need to know. Nagel's rule. So we have our client coming in the office. We have to figure out how far along she is. If she knows the first day of her last menstrual period, we can use Nagel's rule. What if she doesn't know?
Ultrasound?
Ultrasound, yeah, especially if it's in that first trimester. The length of that embryo or fetus, we can correlate. If it's 14 centimeters from the head of the baby to the butt, crown to rump is 14 centimeters, then the baby is 14 weeks gestation. So Nagel's rule is go back 3 months plus 7 days in a year.
Isn't there another way of doing that too? Like go forward 9 months and add 7 days?
Go forward 9 months, and I've never heard of that.
From like the time, if she tells you that her menstrual is, I don't know, just say today was the last one. So if you go forward 9 months and add 7 days, doesn't it give you the same thing as going backwards 3 months?
It would probably be pretty close. Yeah. Yeah. There's OB wheels that you can also use in apps. There's a lot of apps that you can do, because when she conceives, it's not really when she's pregnant yet. She's not pregnant until that baby's implanted.
Right.
So there's a delay there. Yeah. Don't confuse everybody, Crystal. All right. So here's an example.
See.
September. So we're going to go back 3 months. So it'll be August, July, June, and add 7 days to 19, which would be what? 26.
C.
And then 1 year later. Yeah.
See.
So C is the answer. Okay. Everybody comfortable with that? All right. So gravidity and parity. Remember, gravidity is just the number of times she has conceived. So G is, so read through the statement, how many times did she actually conceive? That's what the G is, the gravidity. Parity is the number of those conceptions or the pregnancies that were delivered after 20 weeks or 20 weeks and after. Okay, so a prima gravida is pregnant for the very first time. A multigravida, she's been pregnant 2 times or more. A nulligravida has never been pregnant. So nulli means 0, multi means 2 or more, and prima means 1. Same thing with parity. Which of those conceptions was a pregnancy that was delivered? So a prima para, she's only had 1 pregnancy that was delivered after 20 weeks. Multipara, she's delivered more than 2 or more pregnancies after 20. And then nullipara, she's never delivered a baby past 20. She could be a gravida 6 and still be a nullipara because she's never delivered. She's had a lot of abortions. Okay. So we have a 28-year-old just delivered. So if you read that, what is her G? How many times has she conceived?
Be 3.
3.
3.
Okay, so she just delivered one. She has a 3-year-old and she had a miscarriage. That's 3. Out of those 3 conceptions, how many babies were born full term?
2.
Correct, because she just delivered one and she has a 3-year-old daughter who was past term. So what about any preterm babies?
No.
Whoops,
No,
what was
that's
that?
an A.
And how many abortions?
1.
1.
1.
And then the last one is, of all the pregnancies, how many living children did she deliver?
2.
2. Okay. Good. So your prima gravida patient comes for her 40th week prenatal visit. How would you know her obstetric history? Let me put A prima gravida. That makes more sense. So this is a different client.
So she'd be G1, T1, P0, A0, L0, because she's still pregnant.
Why did you say T1?
She don't
Has she
have,
del-
yeah, it would be 0 for T because she haven't
T
had
is
one.
0 because she
Yes.
hasn't
Oh,
delivered the
because he
baby
hasn't
yet.
born yet. Oh, okay.
Yep.
Yeah.
0, 0, 0.
Yep. So to shorten that, you could just put G1P0, parity 0. The P in that one stands for parity. Okay, good. All right, let's do it again. How many times has she become pregnant?
5.
5.
5. Okay, she's been pregnant 5 times. How many of those pregnancies were delivered after 36 weeks and 6 days?
2.
2.
Two, okay? All right, how many of those pregnancies were delivered prior to 37 weeks? But after 20 weeks?
One.
Yeah, one pregnancy at 35 weeks,
35.
okay?
So it's
How many of those pregnancies were delivered before 20 weeks? Abortions and
One.
Okay, okay. So this one is correct, right?
Mhm.
So don't forget that she's pregnant currently. Okay, don't overlook that, okay? Let's see, wait a minute. So an adolescent, well, I already wrote the answers in here, I didn't correct it. Adolescent pregnant for the very first time is a prima gravida, right? G2 would be a multigravida. Para 1 would make her a prima gravida. I'm sorry, a prima para. 26-year-old with one abortion and a 38-week delivery would be multigravida because she's been pregnant twice. A prima para because she's only delivered one baby past 20 weeks. Does everybody have a copy of this PowerPoint? You should. A 24-year-old with 3 abortions is a multigravida, but she's a nullipara, nulliparous, multipara. Let's see, wait a minute. 3 abortions, A, multigravida, and she's nulliparous, which is
Wait,
not.
why is that A?
Because she's been
Oh,
pregnant.
pregnant. I'm sorry, pregnant.
Yeah,
pregnant.
multigravida, yeah. But she's also, if we add,
Nullipara.
yeah, nullipara here, she would be then F. Okay? She's not delivered any babies past 20 weeks. She's had only abortions. And then you have a 20-year-old with 2 children. So she's been pregnant twice and she's delivered twice past 20 weeks. Okay, signs and symptoms of pregnancy and adaptation. This is basically memorization, but remember the presumptive, subjective symptoms. These are symptoms. In other words, it's what the client feels or experiences. It's not what we see, not what we can measure. It's what she tells us. She's Mr. Period. What do we call that?
Amenorrhea.
Amenorrhea.
Amenorrhea. Amenorrhea. What's quickening?
When you feel the baby moving.
Yep. Nausea, fatigue. What's another symptom of pregnancy?
Vomiting.
Okay, so that would go
Tender
along with
breasts.
nausea. Okay, breast tenderness. Yeah. Okay. And then probable signs. So these are objective and they're signs, things that can be measured, things that can be seen. Okay. So we do an exam. So this section, the probable signs are what you see as a nurse. Okay. You see she's got a positive pregnancy test. You see that she has a bluish cervix and vaginal tissue, Chadwick's sign. You see that the uterus is very floppy. That's called McDonald's. The cervix is soft. Okay, Hagar sign. The isthmus is soft. Braxton Hicks, probable sign. I don't agree with that, but I think your book says that because it's something that the client feels. But I think your text puts it in the probable. If I can put my hands on her belly and I can feel it tighten, then yes, it would be Braxton Hicks. And then the positive is also a sign. And these are the tests that we do. So we can use our Doppler to hear the fetal heartbeat, or we can do an ultrasound. Also, if I put my hand on her belly and I feel the baby move, that's also a positive sign of pregnancy. So if you try to remember these in the perspective of, is it the client complaining or explaining, or is what you're seeing as a nurse, or what you test? Okay. And then the other side is, what are some changes during pregnancy? Remember, musculoskeletal, we've got 2 hormones. Do you remember what they are? You might not. That cause relaxation of ligaments. Progesterone and relaxin. There are 2 hormones that cause lordosis, relaxed ligaments, connective tissue, pelvic joints, connective tissues. I'm going to put ligaments. The uterus has 3 sets of ligaments to suspend it, and all of those get soft so that the uterus can grow. So sometimes we also have clients that complain about leg cramps. Which one of these integumentary changes is permanent? Everything gets larger in pregnancy, especially moles or any kind of pigmentation. Which one
The
is
stretch
permanent?
mark?
Yeah, striae gravidarum. Those are permanent. They're the scar tissue. They do shrink and they fade a little bit, but they are permanent. The chlasma, or it's also called melasma, same thing. It tends to fade. It might take a little bit longer. That's the face, okay? So progesterone protects. Progesterone also builds that base where that embryo implants to provide all that perfusion. Estrogen is a growth hormone during pregnancy. Uterine growth, breast growth, blood vessel dilation. What would you teach your client about heartburn? If she's having a lot of heartburn in pregnancy, what would you teach her?
To
Eat more
avoid
protein.
spicy food.
And so after she eats, she needs to sit up for a little while.
Okay, sitting up after a while.
To
More
avoid fatty and spicy food.
Yeah, avoid spicy food. What else?
Eat more frequent like snacks or more
Yeah.
protein foods.
Small meals more frequently. Yeah.
And have water, not at the time of the meal.
Yeah, don't drink water
After-
during the meal. Yeah, do not drink water during the meal. Yeah. Nausea and vomiting. We usually can prescribe a lot of different medications. One important thing is, if she does eat small meals, if she can keep something in her stomach at all times, because sometimes an empty stomach will cause nausea. So crackers at the bedside.
Yeah, I think something said to eat maybe carbs at night. I'm not sure if it's carbs or protein. I think it's carbs though.
Protein is good too, though. So
It's
either
protein.
one.
You
Yeah.
pack on protein at night.
Protein at night, yeah.
And before rising, you eat crackers.
Yeah. Okay. So kidney changes, bladder changes, just increased frequency, especially early pregnancy and late pregnancy when that uterus compresses the bladder. She's at risk for urinary tract infection. We treat all urinary contractions during pregnancy with antibiotics. And then knowing that she's going to clot a lot easier during pregnancy, what are some things you want to teach her?
Don't sit for long periods.
Yeah, good, good. Yeah, we want those muscles in her legs to move and circulate that blood. Because the blood tends to pool in the lower extremities the farther along she goes in her pregnancy.
So I had a question with this, with like because I saw an NCLEX question that was talking about leg cramps and how to alleviate them. But then if we're worried about blood clots and things like that, the suggestion it had was to like flex your foot with your knee extended. And like, if you had a DVT, you should not do that.
Right. Yeah. That's true. So if there's a cramp, you definitely want to alleviate it. That's not going to work. Okay.
Right. So do you just teach your patient like signs and symptoms of a clot versus a leg cramp before they were to do? Okay.
So, and those are things that we assess postpartum, particularly, and we teach prevention during the pregnancy. And then we do certainly want to be alert and teach our client about ambulation is very important after delivery because of that. The most definitive, and in other words, we can say for sure she's pregnant. This term right here,
Number 4.
So they're asking you for positive sign, most definitive.
Yeah, number 4.
Okay, so fetal heart tones. You were able to use your Doppler, put your probe on her belly, and you heard fetal heart tones. One of the most fabulous things to experience when a client is pregnant for the first time, even second or third time. Hearing those heartbeat early is exciting. So this one. What's another one?
Chadwick sign.
Ultrasound.
No, Chadwick's sign doesn't tell us for sure. Chadwick's sign, she could have a pelvic congestion syndrome. So it's not for sure. Okay. So we've done Nagel's rule that estimates the delivery. We've talked about prenatal visit, the very first one. And one of the things we do, we draw blood, and for a lot of different reasons, we want to know blood type. Okay. We want to know all her RBC, her hemoglobin, hematocrit. We want to know all kinds of things, her thyroid level and such. Blood incompatibility is not usually an issue unless the blood mixes. Unless the maternal and fetal blood mixes, we're not really concerned about incompatibility. But there's always risk of it mixing. Trauma, early pregnancy abortions. We need to know what her blood type is. In other words, what her status is on certain antigens in the blood and on the red blood cell. So the Rh antigen on the red blood cell is a good information to know. So if your mother does not have an Rh antigen on her red blood cells, then we need to give her some anytime during the pregnancy that she's at risk for the blood mixing. So trauma and abortion, and then delivery within 72 hours of delivery. We need to give her some Rogaine. What we're doing, we're giving her a temporary form of the Rh antigen antibody, you might say, so her body doesn't make it. So we're going to give her some that lasts about 12 weeks, and it'll go away. Okay. And that protects the next baby that she gets pregnant with. Okay, so the only time we're concerned about our RhoGAM is if the mother is Rh negative. Rh negative. We assume that the baby is Rh positive. If we do cord blood assessment, which we do, and we find that the baby is Rh negative, then we don't need to give RhoGAM. Okay.
Can I ask a question about something?
Sorry.
You know how she just mentioned the leg cramp relief? So we extend the dorsoflex.
You extend the knee, and lean forward, stretching that calf muscle for cramps.
And dorsiflex would do the same thing of the foot.
Okay. So we do
You know,
the knee and the dorsiflex of the foot.
it's the same thing.
Oh, okay.
So in other
Okay.
words, yeah, so in order to relieve a leg cramp, if you have your client stand up, put her hands on the wall and lean forward, her feet are farther away from the wall, lean forward, it stretches that calf muscle to help that cramp be relieved. But you don't want her to do that if she has a deep vein thrombosis. Okay, so you could apply heat to the leg. Sometimes that'll help. If she has a deep vein thrombosis and she has a cramp, you could apply heat to that area very, carefully. That'll help that muscle relax as well. And it will help that, won't cause problems with the deep vein thrombosis. If we have our client ambulatory with a DVT in the lower leg, it might dislodge that clot, which would travel to the heart and to the lungs initially, and cause a pulmonary embolus. So that was the issue we were talking about earlier. Okay.
Okay, thank you.
Sure.
Okay, you
What
said
else?
you said that when you talking about incompatibility, were you just talking about the RH negative, or was you talking about ABO also?
Well, ABO is another incompatibility, but RhoGAM's not going to help that. So you either have A type blood, B type blood, AB blood, or O blood, right?
Right.
ABO. That's what that stands for.
Yeah, that
So
happened to me and my baby. I have
okay,
O
yeah.
and she has B, and so her bilirubin levels were really, 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 really high, and she thought
Yeah.
this. And yeah, so when
And
you were
that
saying that the
yeah.
bloods don't mix, so it wouldn't be any harm to the baby. I was a little bit confused, but you were talking about RH negative. You weren't
Yes.
talking about the ABO.
Good point,
Okay.
Cassandra. Good point, Cassandra. Yes.
It's Alicia.
Oh, Alicia. Oh, I'm looking at Cassandra because she has her hand up. Alicia. Thank you, Alicia.
It's okay. You're welcome.
But that's true. And sometimes we don't see that bilirubin go up till later. So when did your baby develop bilirubin? Higher levels?
Right after she was born.
Okay. So
right
there was
after
significant, yeah. Okay, right after. But she wasn't born with jaundice.
Well, I saw they were afraid that she would have jaundice, but I saw the yellow in her eyes before we even left the hospital.
Okay,
And then,
yeah.
but it wasn't until after, the 2-day checkup is when they checked her, and the doctor looked at her and was like, yeah, you need to take her to the hospital because they need to check her bilirubin levels. And when they checked them, they were like, she has to stay in therapy. It was like at 24 or something.
Yeah. Oh, wow. That's high.
Yeah.
Yeah, we don't, usually we check cord blood. Cassandra, do you have a question? You just have your hand up.
Yes, please. When you talked about the rhesus factor, you said when they check the mother's blood and she happened not to have any, she's been given one, and I was wondering what could be a reason why there would be no rhesus factor on the mother's blood.
Genetics, just her blood typing. If there's no RH factor, that's just genetics. That's just her kind of blood. Does that help?
Yes, thanks.
Yeah. If there's no RH antigen on her blood, then we would have to treat her. But we don't know that until we do her blood type, and then we really don't know if this is her first pregnancy. We don't know what kind of blood the fetus has, if that fetus has the RH antigen, which is what the problem would be. Okay. So it doesn't bother the first fetus, it's the next baby that if we don't treat mother and prevent antibodies, because if we don't give her the RhoGAM and she has another pregnancy and that baby has the RH antigen, then the mother's blood has antibodies, and it will actually cause that fetus to some hemolysis of the red blood cells. They become anemic during the pregnancy. The fetus does.
Okay, thank you.
It's very complicated. And the only thing you need to know for this class, and I'm more than happy to talk to you about it afterwards. The only thing you need to know for this class is if the mother is Rh negative, we need to give her some Rogaine. Okay?
Thank you.
You're welcome.
I'm sorry, y'all, my baby crying, but I got another question. Okay, so would what is it called? What does she have? Sickle cell. Would sickle cell be an autosomal recessive trait?
Yeah, sickle cell
Because
is an
the
autosomal.
father would have to carry as well as the mother in order for the child to get.
In order for a child to have a risk for having it. So, but there's only, even if both parents carry that gene,
it's a possibility that they won't get it.
Yeah, there's a 75% chance they won't get it.
Right. But if the mother carries a gene, but the father doesn't, the trait could be passed to the child. But
no, it can't even be it can't even be passed. I don't believe.
Well, I don't have sickle cell, but my daughter has the trait. She doesn't have the disease, but she has the trait. So that means her father carries the trait, right? Because I don't. And my mother doesn't either.
But your daughter has the trait, so
right. She carries the trait, but she doesn't have the disease.
Okay, so she carries the gene, but the father didn't carry the gene. Was the father tested?
No, that's what I'm saying. He has to carry the gene because I don't. We didn't test
both of you have to be tested. Both of you have to carry the gene for there to be a chance for your daughter to have the risk of carrying the gene.
I thought we both had to have the gene in order for her to get the disease, not just to carry the trait.
Okay, so both partners have to have the gene for sickle cell, okay? If they both do, there's a 1 in 4 chance. If you have 4 children, one of them, the risks are that one will have the disease, 2 will carry the disease, have the trait, and 1 will actually be unaffected, not even be a carrier. Does that make sense?
Yes.
Okay. All right. Okay, so
I have a question too, Professor.
Go ahead.
I wanted to ask about what happened if, for example, I have a patient that is on the first trimester and she comes like to be seen and her blood pressure is high or low.
Okay, so you're getting ahead of us, Adriana. We talk about those things in week 5. If she comes for her first visit and she's not 20 weeks pregnant, she has a history of high blood pressure then. She has chronic high blood pressure. But if she is beyond 20 weeks, then she develops high blood pressure, is referred to as gestational hypertension. Okay, so you're getting ahead of us. Okay,
I'm just reading all the materials and everything.
Okay, good. So every time we see our client, we're going to do routine stuff. We're going to weigh her, check her vital signs, check her urine. We're going to check her urine for protein and glucose, nitrates, things like that. And then once she gets into the late 2nd trimester, sometimes we do fetal surveillance if they're high risk. So if you have an adolescent or you have a diabetic or you have a client that the fetus isn't growing real well, we're going to watch the fetal growth. We're going to make sure that fetus is thriving. And we do that through ultrasounds, okay? And we do a BPP, we do non-stress tests, and we'll get to those. But during the prenatal period, we need to teach about nutrition and exercise, preparing her and helping her have a good, healthy lifestyle during her pregnancy to prevent 2nd and 3rd trimester problems. So if you do, okay, we know what this one is, right? Oh, well, maybe not. So she's 32 weeks gestation and she's feeling dizzy and lightheaded as we measure her fundal height. Her skin is pale and it becomes moist. What's going on?
D, circulation, perfusion.
Okay, so she's lying, that baby's lying on that inferior vena cava. So what would you do?
D.
Yeah, we need to
Put a
get,
left.
yeah, we need to get her off that vena cava. And the best way to do it is the left side, because the vena cava tends to be more on the right side of the vertebral column. So we're going to move her on her left side. And that's going to help that blood get back to her head and to her baby and get rid of that dizziness. So her blood pressure dropped. So whenever our blood pressure drops, we do get lightheaded. We might even become diaphoretic. So the first thing we need to do is get her turned over. All right. Dietary. Okay, so know what's a normal BMI. Ideal BMI, 18.5 to 24.99. Obesity starts at 30. Okay, so it's more important that we focus on the nutrition of a client. What is she taking? What is she eating? How much? When? How often? Than it is to be so focused on weight gain. Although we want her to gain about 25 to 35 pounds, we need to be more concerned about nutrition. Is she eating well? Okay. Complex carbohydrates are very important during pregnancy. Okay. The bulk of her calories should be complex carbohydrates and fats. Believe it or not, but she needs that energy for fetal growth. Folic acid.
So out of
DHA.
all I'm sorry. Out of all those, what is the main source of a pregnancy diet? If it was, simple sugars, fats, fiber, complex carbs, what do we put complex carbs? Is that the
Complex
main one?
carbs. Yeah. Complex carbs
Okay.
and fat. More
Okay.
important than simple carbs. Okay. So a complex carb would be like what?
Potatoes, beans.
Rice, pasta. Yeah. Because they don't turn into sugar right away. They have to break down. So it sustains a healthy glycemic level throughout her day. Folic acid, we've talked about. Iron, we need to take that. We need to teach our client to take that on an empty stomach or with some orange juice. Okay. Make sure if you have a vegan or a vegetarian, we do some supplemental B12 and vitamins for her. So what are some B12 foods that that we need to promote?
A lot of for vegan or vegetarian, if you do oat or soy or coconut milk, a lot of them will include B12 and your B complex in there as well.
Okay, so looking at labels is really important. Okay. Pyrosis is a term for heartburn. Okay, so small meals, occasional antacids, but the provider needs to know if she's having frequent heartburn. We need to deal with that. Okay, nausea and vomiting, we've talked about a little bit. Pica, what's pica?
When they want to eat stuff that you're not supposed to eat.
Yeah, craving for food that has no nutritional value.
Okay. So it's usually a sign of iron deficiency, right? In pregnancy, it's a sign of iron deficiency. So we need to provide supplemental iron, oral iron. So anybody that you're concerned about nutrition, teenagers, diabetic, someone who's very severely obese, vegetarian, it's okay to recommend referral to a dietitian, someone with a cultural food pattern. If they, like Indian food or Mediterranean, maybe they're not vegetarian, but they tend to eat certain kinds of foods. Some Asian diets might not have adequate vegetables. Okay. So just a good evaluation of what their intake is. And you can teach, okay? So all the things that make a pregnancy high risk has to do with her history up to this point, okay? We're not talking about high risk that occurs during pregnancy, but anything in her past, chronic illnesses would be part of that, psychosocial, poor access, poor demographics, poor access. I said that, didn't I? So as she does progress through her pregnancy, so I took care of a homeless young lady. She actually was a homeless adolescent. And it was really strange because she came to the clinic with her mother and she was homeless, pregnant. And she was thin. Her BMI was less than 18.5. So with her, she had to be monitored very carefully and educated, and we had to give her the county references or county resources that she needed for nutrition, WIC, and some other things. Get her some insurance so she could get some help with nutrition for her and her baby. With her, then we need to monitor her weight throughout the pregnancy. Check in, maybe have her come in more often. And during that third trimester, when we're concerned about intrauterine growth restriction, in other words, if she's not getting adequate nutrition, then the baby is restricted in its growth. It's not going to be able to grow. So we're going to do more ultrasounds. We're going to do the BPP, measuring baby's reflexes, movement. It's an indication how well baby is doing, how well baby is thriving. And it also is an indication that compromise is occurring. If the baby's not moving much, then we're concerned. Okay, so a BPP gives us that information. We teach mom, be aware of your baby moving. We want the baby to move. There's no standard movement amount but during the day, but if she's not doesn't remember when the last time the baby moves, we want her to stop and pay attention. And we teach her about kick counts. How many times have you felt the baby kick you in the last hour? If they don't know, if they're not feeling anything, or if they're feeling very few movements, then we'll bring them into the office and we'll do a non-stress test. Okay, so somebody explain to me, what is a non-stress test? How would you perform it? Your client's coming in and telling you, she called the office that morning and said she really hasn't felt her baby much move the last couple of days. And so you say, come to the office. So she's there right in front of you. What are you going to do for a non-stress test?
Is that the one where they do like the fetal monitor across the belly?
Well, you
and
put
then
the
they're looking
tocos
for
on,
variability?
and then it determines the fetal movement if they're having contraction, and you can see whether it's having some I want to say D cells.
Okay. So we're going to attach the monitor, like Rebecca said, have mom lie down on the bed. We don't want her to lie flat, right? We can sit her up a little bit, put the monitor on her, and we're only monitoring the fetus, the heartbeat. We're not going to monitor contractions. Hopefully she's not having any, okay? We want to monitor movement and look at what's occurring on the monitor when the baby moves. So the mother has this button that she pushes. Okay, when she feels a baby move, she's going to push the button, which marks the monitor. Okay, and that mark on the monitor, what's occurring as far as the fetal heart rate? Does the fetal heart rate go up during fetal movement? Does it stay up for at least 15 seconds? And does this occur several times within 15 minutes? You don't have to know the specifics. If the heart rate goes up when the baby moves, that's a good sign. That means that the placental perfusion is adequate and the baby is being well oxygenated. Okay. If it doesn't, if the heart rate drops, then there's a problem with placental perfusion. Okay. So this is a non-stress. The reason it's non-stress is because we're not causing contractions. Okay.
So Professor, I have a question.
Yes.
With acceleration, you said oxygen. Is that the same thing? Are we monitoring for acceleration?
Yeah, we want to see the heartbeat go up when the baby moves. Definitely. Accelerations are defined by heart rate that rises above for a certain amount of time. That's what we call acceleration. Okay. So yes, it's the same thing. We want to see the heartbeat go up when the baby moves. And sometimes if the baby's not moving, we'll put some music on our phone and put it on mommy's belly and stimulate the baby to move with music. Sometimes that makes them move. Okay. Versus a contraction when we give medication like oxytocin to cause a contraction to see how baby fares during a contraction. During a contraction, does the uterus reperfuse very quickly? In other words, if we do a contraction stress test and baby's doing well, then we know she'll tolerate labor fine. Okay, that's the difference between the two. So we want a reactive non-stress test and a non-reactive contraction stress test.
Can I ask a question back to the BPP? Can you explain how you do a BPP? Because I was trying to figure it out and it wasn't clicking.
Okay, so a BPP is basically an ultrasound.
Okay.
With a non-stress test. So an ultrasound, and during the ultrasound, what we're looking at 4 parameters. So there's a total of 8 points. Each parameter gets 2 points. Is the baby extending and flexing extremities? Is there good reflex activity, in other words? Okay. Is the baby moving? Does it have good muscle tone? So that's the second one. Another one, is a baby swallowing amniotic fluid? In other words, we call it practice breathing. Okay, you can actually see them swallow. And the last one,
they should swallow.
it's a good thing. Yeah, it's a good thing. And then the fourth thing is volume of amniotic fluid. Is it adequate? And we usually do that by index. The machine does it for us. So there's 4. So a total of 8. A lot of times
go ahead.
A lot of times what you don't see is the practice breathing. So we have them go out, have lunch, come back, and we redo it. And a lot of times they are practice breathing.
And you said you do that with a non-stress test?
Yeah, usually yeah. It's called a modified BPP would be without the stress test.
Okay. Thank you. I appreciate that.
Yeah, sure. Let's go to intrapartum. So our client, if we had to induce her or she's in labor spontaneously, it doesn't matter. We're going to talk about what affects good labor progress. In other words, she's having contractions, the cervix is dilating, it's effacing, baby is descending, and we're going to deliver. Now, we don't want to deliver within 3 hours. That's precipitous problems. Okay. And we want to deliver before 24 hours because we're worried about infection. Okay. So some things that affect that baby passing through that passageway. So the passenger, okay, that's the biggest effect. Okay. The size of the baby, the lie of the baby, whether it's cephalic, break, breech, whether it's transverse. Okay. What baby size, the head of the baby, just overall weight of the baby can be a hindrance. Okay, and the descent of the baby, position. Where is, if the baby is head down, cephalic, where is the occiput? Is it in the front or the back? That makes a difference. Is the baby flexed? Is that head flexed? So those are all things with the passenger. Okay. So that affects the progression of labor. But also another thing that can affect it is the mother's anatomy. What if she has a very platypoid or very flat pelvis? Or a gynecoid, which is the ideal structure. It's the skeletal structure or the soft tissues. In other words, is there something about the mother's anatomy that hinders the baby's descent? And then powers. Are her contractions effective? Are they occurring, the frequency, are they occurring often enough? What's too much?
For the contractions, it's supposed to be 5 or less in 10 minutes.
Exactly. If it's more than 5, what's the problem with having 7 contractions in 10 minutes, other than mother's exhausted? What's the problem?
The baby is not breathing well, because it's too much time compressed.
Okay, so the baby's not breathing, but it's the uterus is not being perfused, right? During a contraction, there's no blood flow to the placenta. Okay, and so if that is occurring frequently, then we know that the baby's becoming hypoxic. Okay, so we want only 5 or less contractions. So the powers, contractions that are changing the cervix, and then the pushing, right? The other power. Position of the mother. She needs to change positions during the active phase. And then, of course, psychological. And that can affect labor. She's anxious. The stages and the phases of labor. Remember, we can say, yes, you are in labor, your contractions are regular, and your cervix is dilating and effacing. So you are in labor. But if those two things are not occurring, whether her membranes have ruptured or not, whether a baby has dropped or not, if she's not contracting regularly and her cervix is not changing, she's not in labor. She's not in true labor. Okay. So labor is stage 1, right? Stage 2 is delivery of the baby. Stage 3 is delivery of the placenta. So each first and second stage have transition stages where they're transitioning from the current stage to the next one. That urge to push sometimes will occur during the first stage of transition when she's not really fully dilated. She can have that urge to push, but we don't want her to push until she's fully effaced and the cervix is fully dilated. Okay, and then we can allow her to push. So the second stage, when the cervix is fully dilated and fully effaced, and the fetus begins to descend and the contractions are frequent, and she's pushing, it can take 2 hours to push. And research shows us that we don't want to rush the stage 2. We want the fetus to descend according to a very regular fashion and don't rush it. And we'll see why when we talk about the newborn, why that's beneficial. So once that baby is born and mother is doing skin to skin and we've clamped the cord, now we expect the placenta to be delivered in stage 3. And during this time, we're going to give her a bolus of oxytocin. Because when we give her a bolus of oxytocin at that time, a stronger dose, which we can do now that we've already delivered our baby, it helps the uterus to contract really well to release that placenta and reduce bleeding. Okay, because we're concerned about bleeding during the postpartum. Okay, so she's going to continue to have contractions during placenta delivery. She's going to feel some fullness, and you're going to see a gush of blood. Okay, so usually for a vaginal delivery, 500 mLs loss of blood. Cesarean is going to be twice that much.
Is that fluid loss just from the fetal delivery, or is it for the fetal and the placenta?
both. It's a total. It's a
Okay.
total amount. Yeah, it's a total amount. Estimation. It's an estimation. So how do we manage, how do we help our clients during labor? You know, what are some pain management strategies that we can use other than medications? Non-pharmacological things.
Breathing technique.
Yeah, breathing techniques. If she didn't go to childbirth classes, then we're going to have to really be vigilant in helping her to breathe. So it's going to be different. Early labor is going to be more slow, deep breaths, focusing, whereas late, when she's really hurting, it's going to be faster breathing and more shallow panting. We can do massages, showers, warm water, tubs,
So I
aromatherapy.
I saw the thing in the book where you can do a water block.
A water block, yes.
Yeah.
So that's, yeah. So injecting intradermally into the dermal space, water or saline.
Okay, and that's safe as far as like infection and nerve?
Yeah, you have to do it. You have to use sterile technique. Yeah.
Okay.
But yeah, you certainly don't want to inject without cleansing the area with maybe some iodine or something. But yeah, you can do that, and that helps. It's like gate theory. You're stimulating different nerves.
Gotcha.
Okay, it's a distract. And then counter pressure, pushing on that back sometimes will help. So what's the most common medication that we use for pain management?
Epidural.
Epidurals, long-acting bupivacaine, something like that, that will provide pain relief for a long time. So we can do this, and we usually don't put them in until active labor, till she's about 4 centimeters, because we don't want to put it in too early and it wears off before she gets to that transition phase. But then again, it's not going to do any good if we put it in beyond 8 centimeters, because most of her pain, remember, is the perineum and not the abdomen. So we're going to do what's our choice during that transition phase if she wants pain management. What's the best choice?
The pudendal.
The pudental block, when we block those nerves in that area, and it's the pudental nerve on both sides, and that'll provide some pain relief in that area, especially if we have to do an episiotomy or some kind of laceration repair. So fetal monitoring, when we're monitoring the fetus during labor, remember that during a contraction, the blood flow to the placenta is shut off, basically. And so therefore, the oxygenated blood to the fetus is reduced. Okay, so a little hypoxemia during that time, which if the placenta will reperfuse quickly after the contraction, it's not usually a problem. Okay. But if it doesn't, then hypoxia will develop, and it accumulates over time during labor, and it can cause the baby to become acidotic. So we can do internal monitoring as long as those membranes, the amniotic sac is ruptured and that cervix is dilated. We can do the internal monitoring to get a better picture. So know the normals of fetal heart patterns. The heart rate, 110, 160, moderate variability, okay? No late or prolonged decelerations. And so if you still don't quite understand this stuff, memorize veal chop and you'll know what to do if you're asked. The number one thing, if you have late decelerations or variable decelerations, repositioning. Shut off the medication, the oxytocin, and reposition your mother. And this is just pictures of deceleration. So if you have decelerations, if you notice, what would be the first thing you would look at on the monitor next?
When it's happening?
When
What
it's
type of
happening.
deceleration it is?
Yeah, to define the kind of deceleration it is. When does it occur in relation to the contraction? Okay, if it's occurring at the same time, there's a mirror image, it's an early deceleration, and we're not concerned. What we're concerned about is if that heart rate drops as the contraction is subsiding, which means the placenta is not reperfusing. Okay, so that's a late deceleration. And you want to shut off the oxytocin and turn her on her side. So these are two mnemonics you can memorize. I've always taught you the spoiled one, stop the Pitocin and reposition the mother. Okay. If you don't have a choice in your question about stopping the Pitocin, then you want to choose position change. Okay.
I have a question, Professor. On Tessa's review, she told us to go to the least invasive.
Okay.
Which is to turn the patient on the side, because the question that she had, it had both to stop the oxytocin and also to put the patient on the side. So we didn't know which one to pick, and she told us to pick the least invasive because the question did not specify that it was the Pitocin.
Okay, so invasive, least invasive. The IV is already in place. So we're not actually performing an invasive procedure when we shut off the IV. Okay. So if you don't shut off the Pitocin, your mother is going to continue to have a lot of contractions, and you want to stop those contractions. So you need to do that first.
Yeah, but some of the questions, even on the NCLEX, it says to put the mom on the side first.
But is there a choice on that question to?
No, it was both the oxytocin and the put the mom on the side. Both were in the question.
Okay.
Both were the choices. So we had to pick one, and that's what she said. So we were confused because we learned that we have to stop the Pitocin first.
Deceleration. Hi, Professor, it's Jeannie.
Yeah.
So depending on the deceleration of the baby heart rate, are you able to hear me?
Yeah, a little bit. Go ahead.
So Lisa and I were discussing that, like, do we stop the Pitocin or do we change the position depending on the deceleration of the baby's heart rate? But on Tessa's review, it said to change the position with the, what was it again? It was a deceleration, a late deceleration. However, our books told us to stop the Pitocin first because
then
because even if you do change a position, if it's the Pitocin, they're still going to have the late deceleration, right?
Yeah, yeah. And really, as you become a competent nurse and OB, you're kind of doing it at the same time. You're calling for help, you're getting her over, and you're shutting the IV off. It's like you're doing it, you're multitasking. But if the book says to shut off the Pitocin, that's what you need to go with. Okay.
So if it comes up on the test, you guys will be able to differentiate that, I guess, or we won't have a tricky question like that.
I don't think I'll have to look, but certainly it's a great question. So if it does come up that there's a problem and a lot of students missed it, and there's, it's keyed one way or another, we certainly will take all of that into consideration and have to give everybody credit for it. Okay. So so the tests are built upon the book. So whatever the book says, that's what you need to go with.
Can you hear me?
Yes.
So I do have a question. So in that question, this is for the student who mentioned the question that said turn the mother first. How was the question worded? Did it ask you as in like, what do you do first? Because you can only do one thing first. So the fastest thing you're going to do is turn her.
Yeah. Okay. So on that question, it asks what's priority, what we're going to do first. However, I just did my NCLEX question, and that one mentioned that the mother is on Pitocin. So I guess they were shooting that one out to see, okay, now you have the medication. Because the other question, I'm just assuming that the mother's on it and assuming that the what is it, the uterine placenta. Now that one is saying, okay, change of position.
So yeah, if it doesn't have Pitocin in the list, then you know
Yeah.
you're going to have to change the position. Yeah, yeah.
So that
Not
that's what
every
Lisa,
yeah. Not every client has Pitocin running. The majority do. Okay, because we want effective contractions. We don't want labor to occur any longer than necessary. Okay. But those are good questions.
I have one more like question about this topic. So when it is like in Word, like when it is in a question format and it's not in a, if there's not a picture of the accelerations or the decelerations and it's just like a question describing the type of acel or decel, how do I, in the wording, how do I differentiate like what type of deceleration or acceleration it is? Like, is it, you know what I mean? Like the
Yes.
words.
Yes. Okay. So they're not going to have strips on the exams and they're not going to be on the HESI. Okay. They will identify, they'll say variable deceleration, or they'll say decelerations that are occurring at variable times or between contractions, both between contractions and during contraction. That's the words, they're going to define it for you. What would you do? Or contraction is occurring as a deceleration is occurring as a contraction is subsiding, you know, it's a late one. So they might define it for you, or they might use the word late deceleration. So you're not going to have a strip to look at. You just have to know what a late deceleration is.
Okay, I didn't know if there was going to be like abrupt or like, I don't know, or like crazy words. Like I didn't know. So I'm like, I hope there's not tricky words.
Yeah.
So, okay, hopefully not too confusing. Thank you.
Okay. You're welcome. So you can look at veal chop and be familiar with it. So variable is abrupt. Okay, they're going to all of a sudden drop because it's the cord. So what you do with a variable, you're going to move her up her hands and knees. If Pitocin's going, yeah, you're going to shut that off and get her up. Okay. So which one? So Katie, this is a good question here. So which one of these requires you to immediately intervene?
Is it? I don't know this. I actually, I think maybe B or maybe second.
I would say, is it number 3?
What's acme? What's acme mean?
I don't know. I thought that was a spell check.
It's at the top of the contraction.
I wanted to say peak, but I seen peak up there, and I'm like,
Yeah, peak of the contraction. So which one do you think it is?
Oh no, it's 2. A deceleration is a decrease in rate that occurs after the peak of the contraction.
I'm going with B.
Yep. That's absolutely right.
Yes, ma'am.
Because the mirror and the acme are the same thing. Okay,
Yes,
when heart rate drop, and that's the head's being compressed. Okay, but if it starts to drop after the peak, that means that it's the placenta that is not being reperfused. Okay, the increase in heart rate to 180 is high, but then it quickly drops back down.
Which is
so that's like a quick acceleration. Yeah, which we like to see.
So what does acme mean?
It means at the peak. So
Oh,
you have the acme is the peak, and the very bottom is called nadir.
Nadir.
well,
Okay,
wouldn't it be like
nadir.
if it happens at the if a deceleration happens at the peak of the contraction, if that's when it's starting, wouldn't that be the same as B? Wouldn't that be the same as the second?
No, because it's telling you that it's decreasing after the contraction, after the peak of the contraction. 3 is telling you that it's occurring at the time of the contraction, which is normal.
I don't know.
And the reason the acme and the mirror is when the head is compressed, and that's the vagus nerve that's being stimulated that causes a deceleration.
So is acme another term for mirror?
Yes.
Okay.
Means the
Okay.
same thing. Yeah.
Okay. All right.
So
I'll remember that.
1 and 3 are the same thing.
Okay.
So you had to know what the word acme meant.
Right.
All right. What about this one?
D.
Yeah, the cervix is completely dilated and effaced, right? The beginning of the second stage. That's when it starts, when the baby begins to descend. Second stage.
Professor, this is another question that Tessa, Professor Tessa did, and she said it was B.
However, this is Janique now. I thought it was D because D begins the second stage of labor.
Yeah, because remember, second stage, you're pushing that thing out.
Yes, but on Tessa review, it said it was B and I was confused, unless she meant to say it was D. Yeah, she said B, however, D is the second stage with effacement, correct?
Yes. So contractions are regular, it's just referring to labor.
Yes.
This is specifically talking about, this is how important it is for you not to go quickly through your exam and read the question, the beginning of the second stage. Okay, the beginning of the second stage of labor is when the cervix is completely dilated and effaced. Even though it doesn't say effaced here, this is the only correct choice. What?
I said, thank you for the clarification.
Oh, you're welcome. Okay, so we have a, we're going to do GTPAL. Let's not do that one. So we have what is a reassuring fetal heart tracing or pattern? Okay, moderate variability, accelerations, and no decelerations. That's very reassuring. So baby is doing fine. Okay. And she's rocking in her chair. So it doesn't say whether she's in active phase of labor, but it's a reactive or a reassuring fetal heart pattern or tracing. So we've already talked about non-pharmacological. So 2 hours later, our client, the contractions are getting stronger. And now she's requesting an epidural. Okay. Baby's heart tracing or heart pattern is still reassuring because it has moderate variability. It changes 6 beats to 25 beats more or less per minute. And there's some acceleration. So that's good. It's reassuring. It's reacting. Baby's reacting to the environment. However, after we put the epidural in, what happens? We're starting to see some decelerations and minimal variability. And now the patient's blood pressure is 76/42. What happened?
Is that because it's reacting to like any of the opioids? It's like
no, she's experiencing hypotension. That's the problem.
The hypotension, yeah. Epidurals don't have opioids in them necessarily. They have an anesthetic like bupivacaine, a long-acting anesthetic that blocks the sensory.
This is a problem for pregnant women.
Yeah. So epidurals cause blood pressure to plummet if we don't treat her with some extra IV fluid before we get started. So what would you do?
You're going to give fluids. Well,
Okay,
first,
so
move around a little.
let's read this again. Let's read this again. After the epidural placement, the fetal heart tracing begins to show late decelerations with minimal variability. The nurse notices the patient's blood pressure is 76/42. What is the first thing you want to do?
You're going to move over to the left side.
So you're going to reposition her.
Not seeing improvement in mom's blood pressure, then we're going to give fluids, but we're keeping an eye on baby.
Yeah, so we're going to reposition her, and then we're going to give her fluids, right, and oxygen. Do both, do all three, but do the positioning first, okay? Fluids, oxygen, after you turn her over.
Professor, I just want to say something to all the ladies on here. And Professor's not going to agree with this, but if there is a question on that test and you do not know the answer and you see hypotension, you better pick hypotension. Hypotension.
Or if you're not sure, just turn your client over, right?
Yes. Either turn
If you
them or
have a
one or the other.
So I do have a question with this because one of the NCLEX questions that I saw had something like this. And it was a select all, and one of the options was whether you used a simple mask and we're doing 8 to 10 liters of oxygen, or doing a nasal cannula. Are you going to just start with a big open flow of oxygen and take her down from there? Is that kind of the mindset?
Okay, so you know, if you want to give more than 6 liters a minute of oxygen, you have to use a mask,
You need a
right?
order. Yeah.
Okay, so if you're in an emergency situation like this, you're going to use a non-rebreather mask at 10 liters. So open it wide, get her a non-breather. In other words, a mask where she's not breathing any of her own air. She gets full of oxygen only. So we can give her 100% during that time.
Okay.
So non-rebreather mask. At 10 liters, just open it wide up. Wide open. So because the blood pressure is low here, the fetus blood, the oxygenated blood to the placenta is reduced. Okay. Okay. You know, and it's really important. You guys are asking really good questions, and it's really important. When you mention NCLEX questions, said something like this, it was similar to this. Remember, you have to read the question. Make sure you're reading to get the information you need. Don't make any assumptions. Just go by what you read in the question. All right. So that's why it says rephrase it. Okay. Don't read into the question. Go with your gut feeling, but make sure you don't do that until you read the question at least twice. Most students fly through the exam. You need to slow down, okay? And avoid that what if game. So absolutely least invasive to most invasive. But an IV fluid that's already running is not considered invasive at that point. Who doesn't know their math? Who has trouble with math? Make sure you know your math. You're not going to be asked, you've got 5 math questions to answer on this exam. And they're sprinkled throughout the exam. You will be allowed to use a piece of scrap paper, but you'll have to show it to me or to your instructor before you use it. If you have an eraser board, like a dry erase board, that is allowed. And when you're done your exam, you have to show me that you erased it. Okay, that's preferred. Okay.
Are there any next gen style questions?
Yes, there'll be 3 or 4 of them on there. So if there are, I don't think they're going to actually use them for grading purposes. They might still be using them as a pilot. So if your instructor, she should have been giving you some of those already. Okay, so
are we gonna have like 52 questions instead of 50?
No, it'll be, I don't know how they do it, Katie. I don't know how they do it, but it'll be all proportional.
Okay, I hope they're still in pilot mode.
Girl, me too.
Me too.
I'm sorry, what did she ask who was gonna be on the exam?
Next
NGN style questions.
Oh, okay. So you guys are not using it for grading? It's a pilot? I didn't know that.
No, she doesn't know.
I don't know for sure if they're pilots still. I imagine they are. Because y'all are still
They're
learning
probably
them.
not. They're probably not.
So we just took our MedSurg 1 test, and it had I think like 4 or 5 next gen questions on it, and they were counted toward our grade. So I don't know if that's necessarily like just the way our campus did it, or if it was
Okay, so just remember the NGN style questions, just read the instructions. And if you have an NGN style question, it says matching or drop down, you know how to do those things. You know how to drop down. It's about prioritizing. Okay, most of them. Okay. Don't let it get you all caught up. Okay. Good luck. And then, so there's a bunch of questions here. You're welcome. The rest of this is questions. So, and after the question, it gives you the rationales. So, you can work on that on your own. We've been on here for almost 2 hours, and I do want to stop right now, unless you have some questions.
Can I ask one question about Down syndrome?
Yes.
Is Down syndrome and trisomy 13, is that the same thing? Or sorry, not trisomy 13, it's 21.
21, yeah. An extra chromosome, an extra autosome, Down syndrome, Patau, Edwards, they all have extra chromosome on a particular autosome. So they have, instead of a pair, they have 3. You don't need to know. Yeah, don't get hung up on all that stuff.
Okay, all right. Let me see if I had any other ones.
Okay. Y'all have been super duper with questions. I love it. Cassandra, do you have a question?
Please, I wanted to ask if you did already posted the PowerPoints that we just had now in the review.
Yeah, it's in there, but I can repost it if you want me to.
Yes, please.
And I'll be putting this recording up in the announcements too. It says exam 1 recordings. I'll put it in there.
Okay, thank you.
You're welcome. But I will add the PowerPoint to that, okay? So that you have it.
Thank you.
With my little notes I put in it. Maribel, Maria Isabel.
Yes, so one more. So I have, you had mentioned if a person has a BMI of, let's say 17.5. I know you said the normal was 18.5 to 24.9.
Right.
So it would be normal for them to gain 25 pounds during pregnancy. That's an okay thing, right? Okay, just wanted to make sure.
Yeah. So what we like to see is them gain 1 to 4 pounds during that first trimester. Okay. But we want to see that, but some women are sick and they don't gain it. So so it's really just as important to look at, what their nutrition is. What are they eating? How much? So yeah, and we include that in education. Good question though. So during the 2nd and 3rd trimesters is about 1 pound to 1.5 pounds a week.
And in if the fundus is boggy, you want to massage it, right?
Yeah, that's postpartum. We're not getting into that.
Okay.
You're not required to know that. Yeah.
Okay.
Yeah, my class, we're going to have fun this week. Yes, Rebecca.
So I was going to ask with fetal positions, the lie, the attitude, all of that kind of stuff. How much do we need to dig in and really be able to identify those for the exam? Because I know that's the part I'm struggling with is learning all of the different attitudes, the different lies.
Okay. I think probably what you need to understand is that the fetal lie, the position affects labor.
Okay.
Okay.
Yeah.
Yeah. I don't think it's going to be any more specific than that. Just knowing the things that affect labor progress, the 5 Ps.
Okay.
Know
And
what
would
they
it be-
are.
With that, would it be like which ones are more dangerous or more postponing to like a labor?
So, for example, the passenger, what would affect labor? The size, right? The size. Okay. The passageway, maybe she's had some surgery and it's affecting her labor progress. Or the mother is very anxious and it affects the progress of labor.
And
Okay?
they say
Things like, it's like
what's
that.
the women in Africa to get like sewn back up. What is the name of that?
Episiotomy.
Not that one, but they like. How somebody
Are you
help me?
talking about circumcision, female circumcision?
Yes, that one.
Oh, yeah. I know
Yeah.
that I think we mentioned that in class one time with how that
At the
can affect
beginning, we talked
labor.
about with
Alternate
any
three.
kind of female circumcision, exterior removal of the genitalia sometimes leaves scar tissue and it might not allow that perineum to stretch well. It's not as elastic, so that might inhibit labor. And so we discussed that during the antepartum. What are we going to do? Okay, what do we want to do? We can actually send her to a women's health physical therapist to help her with exercises to help make that tissue more elastic.
Okay.
You don't need to know all that.
No, I think that's interesting though, because
It is, yeah,
a lot of
yeah,
times
yeah.
you do have such a small opening after something like that is done. So.
Yep.
I just need clarification. The exam that we're going to be taking, is it over weeks 1 and 2 or 1, 2, and 3?
1, 2, and 3. So intrapartum as well.
Okay. Thank you.
Yeah. We talked about the stages, the powers of labor, and the fetal monitoring, the different heart patterns that the fetus experiences, decelerations, what we need to do. So that's all week 3, last week.
Okay. Thank you.
You're welcome, Ashley. Any other questions? Excellent.
I have
Excellent
one more.
questions.
This
Yes.
is the last one, I promise.
That's okay. No.
So I have the biophysical profile. I know you did mention that it was to assess the fetal well-being, but is this invasive or is it non-invasive?
No,
Okay.
it's not. It's just an ultrasound.
Oh, okay. All right.
Yeah, it's the ultrasound doing different parameters of fetal behavior during the ultrasound. And it usually takes 30 minutes to do. So we're watching, did the baby extend and reflex and extend the arm or the leg? We want to see movement. Is the baby moving well? Is the baby swallowing amniotic fluid? Practice breathing. How much amniotic fluid is there? And it gives us an indication of the well-being. If the baby is not practiced breathing and is not moving much, it's an indication there's some compromise going on. And we have to determine what we need to do at that point. Okay.
Okay, thank you.
And if we have a young adolescent, we might be doing ultrasounds every 3 weeks. We can do an ultrasound to see fetal growth. Okay. The machine measures the growth percentile of the fetus during the pregnancy. So if it's below 10%, then we're concerned about some intrauterine constriction or restriction. Something is restricting the growth of that baby. What is it? Is it she's smoking, she's not eating right, or it might be something else? So we have to monitor that growth, because sometimes if we're at close to 36, 37 weeks and that baby's not growing, the baby's at that 5th percentile now, we need to go ahead and deliver, because that baby's going to do much better outside the uterus than inside. Okay, so that's another reason for doing a BPP.
A question: do we need to know like the betamethasone, like for surfactant? Okay.
No, the betamethasone, that's more high risk.
Okay.
Okay. Good, great questions. I wish I had the same group when we do our next exam. That'd be fun.
Thank you so much.
Thank you for coming, everybody. Great
Thanks,
discussion.
Professor
Good
Penny.
question. Yes.
I have one more question.
Yes,
Have a good night, man.
you too. Thank you for coming.
How much do we need to know like the different stages along the antepartum, like different checkpoints of
Okay,
growth
okay.
and things like that?
Well, you need to know about antepartum testing. Okay, you know, we do the carrier screening. You need to be familiar with the carrier screening. You need to be familiar with the MSAFP, the AFP testing.
And like when you can do those?
No, you don't need to know when.
Oh, okay.
No.
Perfect.
Just that you do them. Okay.
There you
Yes,
are. Okay, good.
Do we need to know like when you can hear a heartbeat, when you can, when
yeah,
you should
well,
feel
you
movement?
should, yeah, we usually can hear that. I think your book says 9 weeks, and I've heard one as early as 9 weeks, not prior to that.
Okay.
And you know, the umbilicus, what if you palpate that fundus and it's at the umbilicus, how far along is a mother approximately?
12, 14, I don't know.
20 weeks.
20 weeks.
Is
Yeah,
that-
around, yeah, the fundus that's around the umbilicus, kind of right there, is about 20 weeks.
So that's like the halfway point when the fundus hits the umbilicus.
Basically, yeah,
halfway. Okay.
yeah, uh-huh.
20 weeks. Umbilicus.
Okay. And then would you say like centimeters of growth is kind of equivalent to how many weeks along the
Yes,
mother is?
it correlates. Yeah. So if
Okay.
you measure and you measure from the pubic bone and to the top of the fundus, and it says, and you measure 24 centimeters, then it's that's about how far along she is. But we
Okay.
don't do that until the 20th week and beyond.
Okay.
Okay.
Solid. Cool. Well, thank you, Dr. Zeller.
You're welcome. Anything else? Everybody just hanging on so they can hear every last word?
You're right.
Thank you again, everybody. Bye-bye, Rebecca.
Bye.
Bye.
Bye-bye, Cassandra, Siani, Nisi. Nice to have you here. See if I can find my cursor here.